All right, welcome back to the deep dive. Today's mission is, well, let's say it's surgical, it's precise, and it's definitely high stakes. We're doing an intensive exam-focused deep dive into the pharmacology of three core intermediate-acting non-depolarizing neuromuscular blocking agents. That's Atracurium, Vecuronium, and Rocuronium. So if you're preparing for your final MD anesthesiology exams, this is the high-yield structure you really need to master. We're building the perfect 20-mark answer and the bulletproof Viva defense.
That's precisely the objective. Our aim here isn't just to, recite a list of facts. It's to teach you how to juxtapose these agents, both clinically and pharmacologically. Every single detail we cover is verifiable, designed to differentiate your performance, and we're going to focus on the traps, the kinetics, the active metabolites, and of course the organ system failures that challenge predictability. Mastering this comparison is the difference between a pass and a distinction.
Okay, so let's start at the absolute foundation, just as any long answer must. Defining NDMRs. They are drugs that produce skeletal muscle relaxation, and they're classified chemically as quaternary ammonium compounds. Before we even get to the NMJ, why should the examiner care so much about that specific chemical structure? What's the implication?
Because the quaternary structure is, well, it's the whole story of their systemic pharmacokinetics. Having four organic substituents attached to that central nitrogen atom makes them highly positively charged, highly ionized at a physiological pH of 7.4. And this strong charge, it makes them highly water-soluble.
Which means they can't easily pass through lipid membranes.
Exactly. And clinically, that translates into two critical facts. First, poor oral absorption, and second, they penetrate the blood-brain barrier extremely poorly. And that second point is crucial. It confirms they act strictly peripherally at the neuromuscular junction, the NMJ.
So they have no central nervous system effects. Consciousness is preserved.
Correct. No central effects whatsoever.
So we've established their peripheral. But how do they actually work once they reach the NMJ? The core principle is competitive antagonism at the nicotinic acetylcholine receptors.
Right, the ADHRs on the postsynaptic membrane.
Yeah.
And that receptor is just a beautiful piece of molecular architecture. It's a pentameric protein complex shaped like a rosette, and it surrounds a central sodium ion channel.
And in adults, that's the standard high-dose subunit composition.
Yes, and the critical binding sites are located on those two alpha subunits. Normally, two molecules of acetylcholine, IDH, they bind simultaneously to these sites. That induces a conformational shift in all five subunits. The shift opens the central pore, sodium rushes in, and you get depolarization.
And the NDMRs disrupt this by just physically occupying the site, like the wrong key in a lock.
Precisely. The NDMR molecule, which also usually has two cationic sites, is attracted to the receptor. It binds, and it often binds with a higher affinity than HA itself, but its bulky, rigid structure, it's just incapable of forcing that conformational change. It occupies the space, preventing the right key, HE, from binding and opening the gate.
And here's a detail I think is often missed by candidates, but it's vital. While you need two HE molecules for transmission, the sources note that often only one molecule of a non-depolarizing blocker is needed to block the signal.
That's a very subtle but important point.
Yes.
Because the binding of HE is cooperative, and the NDMRs have such a high affinity, one antagonist molecule can sometimes be enough to prevent that necessary dual occupancy by HE. And that's why the clinical effect, paralysis, develops so rapidly once the drug concentration reaches the effect site.
Beyond the pure mechanism, their importance in modern practice is just foundational. They're essential for facilitating tracheal intubation, for securing the airway, and for providing that optimal muscle relaxation for surgery.
And it all goes back to 1942 with the crude curare extract. That paved the way for all the synthetic alternatives we rely on today. And this brings us right back to exam preparation. We're structuring this deep dive based on the most common question types you'll see. The long answers, those 15 or 20 markers, they demand synthesis, so you'll get comparison questions.
Right, like compare the pharmacokinetics of Rocuronium and Atracurium in renal failure.
Exactly. The shorter notes, the 8 or 10 markers, they'll target specific, unique mechanisms. Things like the details of Hoffmann elimination, the significance of Laudanosine, or the physiology of train of 4 fade. We have to cover this with that level of structural detail.
Okay, let's lock down the classification then. Before we get into individual drugs, the chemical structure is key.
It dictates everything: metabolism, elimination, and crucially, the side effect profile.
So we have two major groups relevant to the intermediates. First up, the aminosteroid agents. This includes Vecuronium, Rocuronium, and the longer-acting Pancuronium. They're all derived from the androstenedione steroid skeleton.
And the defining characteristic of the aminosteroids is that rigid, bulky ring structure. It gives them a high specificity for the HEHR, which results in, generally minimal to negligible histamine release and very high cardiovascular stability. Vecuronium and Rocuronium are both examples of monoquaternary aminosteroids.
Meaning they only have one permanent positive charge.
Right, which significantly reduces the potential for nonspecific binding and adverse effects like ganglionic block compared to their older bisquaternary predecessors.
And the second major group is the Benzylisoquinolinium agents. These have a more linear structure with diester-containing chains. This class includes Atracurium, Cisatracurium, and the historical Depolarizing.
And the defining characteristic here is that structural tendency toward histamine release. Although, as you mentioned, newer agents like Cisatracurium have really mitigated that risk. That linear structure is also the key to their unique non-enzymatic metabolism.
Okay, so placing our three target drugs into this framework. Atracurium is the Benzylisoquinolinium, and Vecuronium and Rocuronium are both aminosteroids, and we classify all three as intermediate acting, typically giving a clinical duration of, 20 to 50 minutes?
At standard intubating doses, yes, that's about right, 20 to 50 minutes.
Perfect. So let's dedicate some serious detail to the mechanism now. This is always high yield.
Absolutely. The interplay of pre- and postsynaptic effects is critical for understanding monitoring. The basis is still competitive blockade. The concentration of the NDMR determines the degree of block.
So the depression of the single twitch response, say, the first twitch, T1 of the TOF, that's a direct result of the postsynaptic block, right?
That's a postsynaptic block, yes. HE just fails to activate enough receptors to trigger a propagated action potential.
But the MD candidate must also understand the origin of fade in detail. This is where people get confused.
The fade is the conceptual trap. When we give a high-frequency stimulus like tetanus or a train of 4, we're challenging the nerve's ability to sustain HE release. That fading response, that progressive decrease in twitch height, is predominantly due to the block of presynaptic nicotinic receptors located right at the nerve terminal.
And why do these presynaptic receptors exist in the first place? And what happens when they get blocked?
Well, they exist to provide positive feedback. During high-frequency stimulation, the released HE activates these presynaptic receptors, which then signals the nerve terminal to mobilize additional HE vesicles from the reserve pool to the readily releasable pool. This is crucial for maintaining a sustained high output of HE and thus a sustained muscle contraction.
So if the NDMR binds to and blocks these presynaptic receptors, that critical positive feedback loop is broken.
Precisely.
I see. So the nerve terminal just exhausts its readily releasable HE vesicles with each impulse, T1, T2, T3, T4, and since less HE is available with each subsequent stimulus, the muscle response just fades away.
That is the level of mechanistic detail the examiner requires. So to summarize the key distinction, depression of the single twitch is postsynaptic. The fade is mainly the result of the presynaptic block.
Which leads us directly to reversal. We use anticholinesterase inhibitors, which block the breakdown of HO. So by inhibiting the enzyme, we just flood the synaptic cleft with native HO.
And this accumulation of HO then overcomes the competitive antagonism by just displacing the NDMR from the receptor. It's a classic example of the law of mass action. More agonist shifts the equilibrium back toward activation.
Finally, let's run through the checklist of factors affecting blockade. The things that can significantly prolong the block. This is a must-know for the Viva.
Okay, we can categorize them. Physiologically, hypothermia is paramount. It reduces metabolism, clearance, and for Atracurium specifically, it slows that chemical Hoffmann elimination. Acidosis, particularly respiratory acidosis, also prolongs the block, mainly by altering the pH needed for Hoffmann degradation.
Then we have electrolytes. Hypermagnesemia is a big one.
A very powerful potentiator, yes. Because magnesium competes with calcium influx at the presynaptic nerve terminal. And since calcium influx is necessary for AC release, high magnesium means less ACS is released per impulse.
And then, of course, drug synergy, volatile anesthetics.
Yes, agents like sevoflurane potentiate NDMRs by reducing AC's release and maybe having a direct effect on the postsynaptic membrane. And antibiotics are critical. Aminoglycosides like gentamicin, they prolong the block by blocking presynaptic calcium channels. Tetracyclines, calcium channel antagonists, they have similar mechanisms. The synergy means you have to reduce your maintenance doses.
Let's transition into the PK/PD properties now, starting with the really critical high-yield concept of onset of action. We're always taught that speed of onset is inversely proportional to potency. Let's break down why.
Okay, so potency is measured by the ED95. Rocuronium, for example, has a lower potency, an ED95 of 0.3 to zero point 0.4 milligiga calculus stack. Vecuronium is much more potent, with an ED95 around 0.1 milligicalams. Since Rocuronium is less potent, we have to administer a much larger molar dose to achieve the ED95 and get saturation.
And that larger dose delivered rapidly increases the plasma concentration much higher and faster.
Exactly. It creates this massive pressure gradient that accelerates diffusion into the biophase, the effect site at the NMJ. It's a rapid flood, not a trickle. And that's the simple kinetic reason Rocuronium beats Vecuronium in speed, even though they're both aminosteroids.
This also highlights the anatomical variation. The block develops fastest in the central high blood flow muscles, like the larynx and diaphragm.
Right, due to rapid distribution. And it's slowest in peripheral muscles. That's why we monitor the adductor pollicis. It represents the last muscle group to be paralyzed and, critically, the last to recover. Laryngeal muscle function can recover significantly while the TOF ratio of the thumb is still dangerously low.
And regarding duration of action, the intermediate classification means they have relatively rapid distribution and clearance. But we have to emphasize duration is highly dose-dependent. For instance, if you increase the Rocuronium dose from 0.6 milligicalograms up to 1.2 for RSI, you can extend the duration from 30 minutes to over 70.
And looking at metabolism and elimination, the divergence here is key for differentiating them. We move from organ-independent chemical degradation with Atracurium to significant hepatic metabolism with Vecuronium and primarily hepatobiliary elimination for Rocuronium. You must know the relative contribution of renal versus hepatic clearance for all three.
Finally, their collective clinical advantage, a remarkable cardiovascular and autonomic effects profile.
Yes, Vecuronium and Rocuronium are known for extremely good cardiovascular stability. They're preferred agents when myocardial performance or heart rate is sensitive. They don't have the vagolytic effects of pancuronium or the histamine release of Atracurium. This minimal hemodynamic impact is why they displace the older agents in cardiac ORs.
Okay, let's begin the deep dive into the individual agents, starting with Atracurium, the agent of metabolic predictability.
Right, Atracurium. It's a Benzylisoquinolinium compound, and the form we use is actually a mixture of 10 optical isomers.
We typically use an intubating dose of 0.5 milligicalograms, which gives us an intermediate duration of about 25 to 40 minutes.
And the single most important exam-defining feature of Atracurium is Hoffmann elimination. If you get a question on Atracurium, you must detail this mechanism.
So Hoffmann elimination is a spontaneous, non-enzymatic chemical degradation. It's a molecular fragmentation that happens entirely at physiological pH 7.4 and body temperature 37 degrees Celsius. And it results in the loss of positive charges on the molecule, forming inactive fragments.
And the clinical significance is profound. Because the degradation is chemical and independent of specific enzyme systems or organ function, its pharmacokinetics are highly predictable. Even in patients with severe hepatic or renal disease, it's a reliable pharmacological constant in highly variable clinical settings.
But this is where the exam trap is. Atracurium is not immune to physiological changes.
Not at all. Hoffmann elimination is significantly slowed by hypothermia, say during cardiopulmonary bypass, and by acidosis. In these conditions, the duration of block can be markedly prolonged, which erodes its key advantage.
And beyond Hoffmann elimination, it also undergoes extensive ester hydrolysis, right, up to 60% of its metabolism.
Correct. And crucially, this is catalyzed by non-specific plasma esterases, not by true plasmacoline-esterase. This is a key differentiator from Vecuronium.
Both of these pathways generate the key breakdown product, Laudanosine. It's a tertiary amine with a prolonged half-life of 2 to 3 hours, and it's eliminated by the liver and kidney. We should discuss its potential toxicity.
Well, concerns were initially raised because laudanosine is highly lipid-soluble and can cross the blood-brain barrier. In high-dose animal studies, it showed CNS excitation and even seizure activity. However, in humans, even after days of continuous infusion in the ICU, plasma concentrations rarely exceed 5 micrograms per ml.
So the safe answer for the Viva is that while the risk is theoretically there, current evidence suggests it's highly unlikely to cause clinical seizures in standard human practice.
That's the safe answer, yes. And it's also worth noting that its isomer, Cisatracurium, has largely replaced Atracurium for continuous infusion. It's 4 times more potent, causes virtually no histamine release, and produces significantly less laudanosine, all while still relying on the same organ-independent Hoffmann elimination.
So summarizing Atracurium's profile, its primary advantage is the predictable recovery in organ failure. And the primary disadvantage is that dose-dependent histamine release.
Correct. leading to transient hypotension or flushing, which means you have to administer it slowly.
Okay, moving to Vecuronium, our first aminosteroid. It's the 2-dismethyl derivative of pancuronium.
And that structural modification, reducing it to a monoquaternary compound, is precisely what makes it more lipid-soluble and dramatically minimizes its cardiovascular side effects compared to the tachycardia-inducing pancuronium.
Vecuronium is a high-potency agent, ED95 of about 0.1 mg/kg, and it's intermediate acting. A standard dose gives you onset in about 3 minutes.
Right, and its shorter duration compared to pancuronium is just due to more rapid distribution and clearance. Now, its PK/PD profile is complex, and this is where an examiner will probe. Its elimination is mainly hepatic, accounting for 50–60%, with biliary clearance being important, but renal excretion is also significant, up to 40% of the clearance.
And the clinical trap stems from its metabolism. It's deacetylated in the liver to form the 3-deacetylvecuronium metabolite.
And this metabolite is not inert. It's highly potent, retaining about 80% of the neuromuscular blocking activity of vecuronium itself.
So this active metabolite is the central risk, particularly in critical care. How does that manifest in organ failure?
In hepatic dysfunction, the clearance of the parent drug is decreased, which prolongs the duration. In renal dysfunction, or the ICU, that highly potent 3-deacetylvecuronium metabolite accumulates rapidly because its renal clearance pathway is impaired. That accumulation is responsible for the prolonged block, sometimes lasting for days, that we see after long-term infusion in ICU patients. That's why continuous vecuronium infusion is largely avoided in critical care now.
Despite those metabolite challenges, its cardiovascular stability is still its key selling point.
Absolutely. Vecuronium is associated with extremely good CV stability. It has almost no vagolytic or sympathetic activity, so its clinical uses are primarily in routine surgery, where that stability is paramount, provided the patient doesn't have severe renal failure and you're just using intermittent boluses, not a prolonged infusion.
Okay, now for Rocuronium, the exam favorite, largely because of its speed and, of course, Sigma-Dex.
It's an aminosteroid, stable in solution, ready to use, and its defining feature is its rapid onset of action. Its speed is entirely kinetic. The low potency, ED95 of about 0.4 mg/kg, means you can give a high molar dose that rapidly saturates the receptors.
The standard intubating dose, 0.6 mg/kg, gets you intubating conditions in about 100 to 120 seconds, and this leads to its most critical role, rapid sequence induction, or RSI.
For RSI, higher doses are needed, 0.9 to 1.2 mg/kg. These doses provide intubating conditions comparable to Succinylcholine, typically within 60 to 90 seconds. It is the drug of choice for RSI when disease is contraindicated, like in burn patients or those with a high risk of hyperkalemia.
But the trade-off is the duration of action. While the speed is great, it's still an intermediate acting agent. And that high RSI dose of 1.2 mg/kg significantly prolongs the clinical duration, potentially up to 73 minutes.
Which was a major liability if you had a can't intubate, can't ventilate scenario. But that risk is now almost entirely mitigated by Sugammadex. Let's talk about its favorable metabolism and elimination. Rocuronium is minimally metabolized, so no clinically relevant active metabolites. Elimination is heavily reliant on hepatobiliary excretion, over 70%, with minor renal excretion.
And that lack of a potent active metabolite is a huge advantage. It makes it a much safer choice for prolonged infusion in the ICU compared to Vecuronium. Other advantages are its speed, excellent CV stability, and the ability to terminate the block on demand with Sugammadex.
The main disadvantage is still that prolonged duration after high RSI doses. And its heavy reliance on hepatobiliary clearance means that clearance is reduced in patients with significant hepatic disease, leading to a prolonged duration in cirrhosis.
So in summary, Rocuronium's clinical uses are extensive. It's a routine agent for RSI, for general surgery, and it's the preferred aminosteroid for continuous infusion in the ICU.
For the exam, you need to be able to recite the standard dosing and, critically, know the rationale for dose modification.
Okay, so for standard intubation, the bolus doses are Atracurium at 0.5 mg/kg, Vecuronium at 1 mg/kg, and Rocuronium at 0.6 mg/kg.
And for RSI with Rocuronium, you increase that to 0.9 to 1.2 mg/kg.
Maintenance doses are generally a third to a quarter of the intubating dose, guided by objective monitoring. And for infusion, Rocuronium and Atracurium are typically run around 0.6 mg/kg. And always, always calculate doses for obese patients based on lean body mass to avoid overdose.
Okay, now for the high-yield comparison point. Dose modifications in organ failure. Let's contrast how these three handle hepatic and renal disease.
In hepatic disease, Vecuronium and Rocuronium clearance is reduced and duration is prolonged. Vecuronium is especially sensitive. Atracurium is the undisputed preferred choice here, right?
Absolutely. Its organ-independent clearance demands no significant dose adjustment, making it highly reliable in liver failure.
In renal disease, ESRD, the picture is defined by that active metabolite accumulation. Atracurium and Cisatracurium are largely unaffected. The small accumulation of Laudanosine is usually clinically irrelevant.
But Vecuronium's clearance is significantly reduced, and that highly potent active metabolite, 3-decetylvecuronium, accumulates massively. This is the specific reason continuous vecuronium infusion is strictly contraindicated in patients with renal failure. Rocuronium's clearance is also reduced by about 30 to 40%, but the absence of a potent active metabolite means the clinical duration of single doses is less catastrophically prolonged than vecuronium.
And finally, in elderly patients, Vecuronium and Rocuronium show slower onset and slower recovery.
Yes, due to decreased liver mass, reduced cardiac output, and increased volume of distribution. It warrants a conservative approach. Atracurium's chemical degradation relies only on pH and temperature, so its recovery profile is generally the least impacted by advancing age, maintaining its predictability.
Okay, adverse effects and complications. This is crucial for safely managing high-risk patients. Let's start with histamine release.
That's unique to the Benzylisoquinoliniums. Atracurium can cause dose-dependent histamine release, resulting in potential hypotension, flushing, and bronchospasm. This is a distinct disadvantage in patients with significant airway disease.
In contrast, the Aminosteroids, Vecuronium and Rocuronium don't cause histamine release.
And regarding direct cardiovascular effects, both are exemplary. They have a minimal impact on heart rate or contractility, making them the agents of choice when hemodynamic stability is paramount.
A major concern, especially after extended management, is prolonged neuromuscular blockade. We highlighted that this is most commonly associated with long-term vecuronium administration in the ICU because of that active metabolite.
Exactly. While Rocuronium lacks this potent metabolite and Atracurium's Laudanosine risk is low, any prolonged infusion of an NDMR carries risk, especially when you couple it with corticosteroids. Rocuronium is often considered the safest choice among the aminosteroids for infusion precisely because it lacks an active metabolite.
And the overarching clinical complication that elevates morbidity is residual paralysis, defined as a TOF ratio less than bright 0.9 on extubation.
And the clinical consequences are severe. It decreases upper esophageal tone, impairs the protective reflexes of swallowing and coughing, and critically, it reduces the hypoxic ventilatory drive. This leads to an increased risk of aspiration pneumonia, reintubation. It's a huge problem. Objective, quantitative monitoring is the only way to safeguard against this outcome.
Which brings us to reversal. We have two major approaches, the traditional anticholinesterase and the new selective binding agents. Let's start with the role of anticholinesterase.
So, anticholinesterase inhibitors, like neostigmine, are indirect reversal agents. They block the enzyme, leading to an increased concentration of native AC in the synaptic cleft. This increased AC then competes with and displaces the NDMRs. And this must always be accompanied by an antimuscarinic drug to counteract the systemic side effects.
But they have significant limitations. They don't work against a very deep block.
No, they're ineffective. The concentration gradient is too severe, and furthermore, most anticholinesterases are eliminated by the kidney. So in renal failure, the duration of the reversal agent is also prolonged, which risks dangerous recurization later in recovery.
So the clinical principle is you only attempt reversal when there's already evidence of spontaneous recovery.
At least one or two twitches present on the peripheral nerve stimulator, yes. That indicates a substantial portion of the NDMR has already been cleared.
This challenge led to the introduction of Sugammadex, the selective relaxant binding agent for aminosteroids.
Yes. Sugammadex is a modified gamma-cyclodextrin. Its mechanism is entirely novel. It's encapsulation. The Sugammadex molecule rapidly binds free Rocuronium molecules in the plasma, creating a massive concentration gradient. This gradient rapidly draws Rocuronium away from the NMJ back into the plasma, where it is encapsulated and rendered inert.
And the Rocuronium-Sugammadex complex is then just rapidly and exclusively excreted by the kidney.
Right. It creates a pharmacokinetic shunt to the kidney, completely altering the clearance profile of Rocuronium and allowing for rapid, reliable reversal, even from a very deep block.
Okay, the core of the exam is synthesizing the differences. Let's distill a comparison of the three drugs into essential exam table points.
This has to be rapid fire. The key differentiators. First, chemical class.
Atracurium is a benzylisoquinolinium. Vecuronium and Rocuronium are aminosteroids. That predicts the side effect profile right there.
Exactly. Histamine risk versus CV stability. Next, onset of action.
This reflects the inverse potency relationship. Rocuronium is the fastest, 60 to 120 seconds, then Vecuronium at about 3 minutes, and then Atracurium at 3 to 5 minutes.
The metabolism pathway is the most critical difference.
Atracurium is unique, Hoffmann elimination and ester hydrolysis, so it's organ-independent. Vecuronium relies on hepatic deacetylation. Rocuronium has minimal to no metabolism.
And this links directly to elimination and metabolites. Atracurium is organ-independent, producing Laudanosine. Vecuronium relies on the liver, bile, and kidneys, producing that highly potent 3-OH Vecuronium metabolite that accumulates in renal failure. Rocuronium is primarily liver and bile, no active metabolite, but its duration is still prolonged in hepatic failure.
And the special advantages are the clinical decision points. Atracurium for predictable recovery and organ failure. Vecuronium for exquisite CV stability. Rocuronium for RSI speed plus Shigamedex reversal.
And we must briefly touch on the crucial Rocuronium versus Succinylcholine RSI comparison.
SC is still the fastest agent, ultra-short duration, onset in about a minute. Rocuronium at high doses matches that speed, but has a duration closer to an hour.
Right. And Rocuronium is mandatory when SC is contraindicated. But the major clinical shift is that Shigamedex allows Rocuronium's duration risk to be reliably eliminated. This has led many centers to adopt Rocuronium as the first-line RSI agent, reducing reliance on SC and its known serious side effects.
Okay, let's anticipate the curveballs and rapid-fire questions from the Viva. You're the examiner. Hit me with the tough conceptual question.
All right. Detail the exact molecular reason why the fade in TO exists and why it reverses more slowly than the depression of T1.
Okay, so the fade is due to the block of presynaptic nicotinic receptors. These receptors normally provide positive feedback during sustained nerve activity to mobilize reserve HG vesicles. Blocking them impairs that mobilization, causing progressive depletion of neurotransmitter release, which is the fade. And because the NDMR must be cleared from the plasma to stop binding these sites, the fade can persist longer than the postsynaptic depression.
Excellent. Now, a clinical dilemma. Patient with end-stage renal disease, 60-minute procedure, you have Vecuronium, Rocuronium, and Atracurium. Which do you choose and why?
Atracurium is the safest default choice. It has to be. The reason is its organ-independent clearance via Hoffmann elimination. While Rocuronium is an option, its clearance is reduced in ESRD, and Vecuronium is strongly discouraged because of the massive accumulation risk of its highly potent, renally cleared metabolite. Atracurium provides predictability.
Good. Now let's highlight common student mistakes and give the safe examiner-approved answers. Mistake 1. Claiming Vecuronium and Rocuronium are completely organ-independent like Atracurium.
Right, so the safe answer is, while they are less dependent on the kidney than older drugs, they rely significantly on hepatobiliary clearance. And Vecuronium is complicated by its highly potent active metabolite, which is renally dependent. Atracurium and Cisatracurium are the only truly organ-independent agents.
Mistake 2. Advocating for reversal with neostigmine when the patient has 0 twitches on the TOF monitor.
The safe answer is, reversal with anticholinesterase should only be attempted when there is clear evidence of spontaneous recovery, at least 1 to 2 twitches. For deep block of aminosteroids, Shigamedex is the only safe and reliable option. For Atracurium, you need continued supportive ventilation.
And your safe answer on monitoring.
Always advocate for objective, quantitative neuromuscular monitoring. Tactile assessment is unreliable in detecting residual paralysis when the T4-T1 ratio is between 0.6 and 0.8, leading to increased morbidity risk.
Exactly. In a theory paper or a Viva, visual representation is essential. A fully labeled NMJ diagram is mandatory if you're asked about mechanism.
Our diagram must clearly label the presynaptic terminal, synaptic cleft, postsynaptic membrane, the acetylcholinesterase enzyme, and the nicotinic AChR structure, emphasizing the adult subunits. And it must visually illustrate the competitive binding of the NDMR on the 2 alpha subunits.
And you must be able to describe the nerve stimulator pattern.
Yes, you draw a graph illustrating the TOF sequence. Decreased twitch height, which is the postsynaptic block, and the characteristic fade, the presynaptic block. And stress the clinical goal. The T4-T1 ratio must be greater than or equal to 0.9 for safe extubation.
Finally, let's reiterate how to structure that 20-mark answer for maximum impact.
We adopt the flow we've used here. Start with a crisp introduction. Follow with classification. Then a major section on mechanism. Next is detailed pharmacology of each agent, emphasizing Hoffmann and active metabolites. Conclude with organ failure adjustments, reversal strategies, and a succinct conclusion.
Okay, let's pull all this into concise, actionable bullet points for final exam review.
High-yield bullet point recap. 1. NDMRs are competitive antagonists. 2. TOF fade is evidence of presynaptic receptor block. 3. Atracurium is organ-independent, chosen for uncertain organ function. 4. Hypothermia and acidosis prolong atracurium's action. 5. Vecuronium is CV stable, but its active metabolite accumulates in renal failure. 6. Rocuronium's low potency gives it a faster onset, making it the choice for RSI. 7. Rocuronium's RSI dose significantly prolongs its duration. 8. Sugamed-X is the game changer for rocuronium, providing rapid reversal. 9. Laudanosine accumulation is a theoretical concern, but generally not a clinical issue. 10. Onset is fastest in central muscles, recovery monitored peripherally. And 11. Quantitative monitoring is mandatory.
Now, synthesize that into a model conclusion paragraph suitable for ending a long answer.
Okay. In summary, the choice among intermediate-acting NDMRs is a nuanced clinical decision dictated by the urgency of intubation and patient comorbidities affecting clearance. Atracurium provides unmatched metabolic predictability in the context of renal and hepatic failure. Conversely, Rocuronium provides the necessary speed for rapid sequence induction, a pharmacological advantage leveraged by the assured, rapid termination of its prolonged action by Sugamed-X. Vecuronium, while offering exceptional cardiovascular stability, poses risks due to potent active metabolite accumulation in critical illness and renal failure. The unifying principle across all agents remains the unwavering commitment to objective neuromuscular monitoring, which is the only reliable defense against the severe postoperative risks associated with residual paralysis.
A textbook conclusion. That covers the spectrum comprehensively.
Now, transitioning back to the clinic, here's the final provocative thought we'll leave you with. Considering rocuronium's prolonged duration at RSI doses and the guaranteed safety of Sugamed-X reversal, does the availability of Sugamed-X mean there is ever a compelling clinical need to reach for an anticholinesterase for rocuronium block in routine practice anymore? And if so, under what financial or logistical constraints might neostigmine still find its place?
A critical question for contemporary practice. Your final step, regardless of that thought, must be to review the comparative elimination profiles of Vecuronium, Atracurium, and Rocuronium in renal and hepatic failure. These specific high-yield differences are what will distinguish your performance in the MD exam. Review those tables thoroughly.
That's a wrap on this high-intensity deep dive. Go crush that exam.